The process of performing a psychological assessment with a patient suffering from chronic pain differs in several important ways from a standard psychological assessment. The goal of this video is to highlight the critical ways in which pain psychology assessments differ, and to discuss practical ways to make these assessments both as effective as possible for the pain psychologist and as useful as possible to the patient completing them. When a pain psychologist receives a referral to meet with a patient, it usually comes from a primary care provider, a pain specialist, or perhaps another type of medical provider. This means that the pain psychologist usually finds themselves with a split allegiance, trying to help both the referred patient and the referring physician. It also means that the usually clear lines of confidentiality between a patient and a psychologist are often blurred with a pain psychologist. Because the referring doctor is expecting to see a written report or receive verbal feedback from the pain psychologist, the patient may worry about sharing sensitive information that could negatively impact their care from their medical providers. Third, and most importantly for this video, a visit to a pain psychologist often raises particular concerns for the patient that are above and beyond the concerns about seeing psychologists more generally. I believe that it is very important for the pain psychologist to be aware of these specific concerns in order to optimize the results of their evaluations. Therefore, let's discuss several strategies for improving pain psychology assessments. The first optimization strategy is to begin the visit by providing a clear rationale for why the patient was referred to pain psychology. In some cases, this might take the form of a question, such as first asking the patient to verbalize what the referring doctor told them about the visit, allowing you to then clarify or fill in the gaps based on what the patient already knows. The rationale should also include the logistics of your visit, such as length and contents, and most importantly, how this visit is intended to be helpful to the patient. In the case of something like an evaluation for an implantable pain device, this rationale may include the value of identifying and possibly addressing psychosocial factors that could limit their benefits from an implantable device. For opioid assessments, the value may be determining ways to decrease the patient's reliance on pain medicines where possible, and explore the need for specialized treatments if the patient is experiencing opioid dependence or showing signs of abuse. Finally, for pain treatment evaluations, probably the most common value is that you will be able to discuss a range of psychosocial treatment options for the patient to consider as ways to enhance their current medical treatments. Where possible, the rationale for a pain psychology assessment should strive to help the patient feel normal about meeting a pain psychologist. The pain psychology visit is most likely to be successful when patients do not feel stigmatized. This is perhaps the most straightforward with implantable device evaluations, as you can relate that all device candidates are required to complete these evaluations. However, even with an assessment based on opioid use or general treatment referrals, it is possible to state that pain psychology is now recommended as a first-line treatment for patients with chronic pain, and that referrals to pain psychology are increasingly routine relative to the past based on new treatment guidelines. In summary, consider ways that you can begin your visit with a short conversation that makes it clear to the patient what you will be doing, how it is intended to help them, and that minimizes anxiety or stigma that the patient may be feeling about the assessment. A second strategy that is helpful to integrate into your assessments is making an early point of discussing the most common fears and concerns that patients tend to have about meeting a pain psychologist. You can't count on patients to voice these concerns directly. In fact, most will not. However, most patients will be thinking about or feeling the effects of these concerns, and if they are not addressed, they can compromise the quality of your visit by causing the patient to be distracted, uncomfortable, or worried about the consequences of sharing their information. Alternatively, discussing these concerns early to address and minimize them creates stronger grounds for initial rapport and a more productive assessment visit. This slide highlights some of the most common fears that patients bring into their pain psychology visits. Depending on the specifics of the visit, some of these fears are likely more prominent than others. For example, a patient referred in part because of concerns their doctor expressed about their opioid doses is more likely to be concerned about the pain psychologist taking away their medicines or perhaps labeling them as a drug addict. On the other hand, a patient with severe depression may be particularly worried about what will happen if they share just how bad things are for them emotionally, such as being hospitalized against their will. Other fears are more routine in pain psychology visits, such as patients feeling unclear about how a pain psychologist can help them, or being concerned about what will be shared with their primary doctor or pain doctor after the visit. Depending on the nature of the visit, consider how you can bring these fears out into the open in the first few minutes of your assessment. Discussing common patient concerns directly usually helps to reduce them, or at least to put them into a more realistic context, and allows the patient to share the specifics of their concerns more clearly so that the pain psychologist can better understand them. The third recommended strategy for improving pain psychology assessments is to increase your focus on functional outcomes with the patient. We are fortunately emerging from the pain is the fifth vital sign era that, for all of its good intentions, had the side effect of making pain severity the centerpiece of pain management discussions for the better part of the last 2 decades. In contrast, the newest pain guidelines support a pain management paradigm centered around function, quality of life, and safety, and pain psychologists will benefit from integrating this new philosophy into their practices at least as much, if not more, than will pain management physicians. Increasing the focus on function in pain psychology assessments means asking the patient more questions about how and where they are currently experiencing functional limitations, and asking more questions about what types of functional benefits the patient would like to achieve from their pain management program. Note that functional benefits can include both things that the patient would like more of, such as returning to work, achieving greater physical independence, and feeling more reliable or useful again, and things that they would like less of, such as feeling left behind by others or less burdened by medicines. A pain psychology assessment, including a greater emphasis on function, can create a deeper understanding in the pain psychologist for how pain is impacting the patient's quality of life, and produce a better roadmap for treatment based on specific and patient-centered goals. The final pain psychology assessment strategy discussed in this video refers to how to conclude these assessments more effectively. In many cases, a patient with chronic pain has had to work through their physical symptoms just to be able to attend and complete the assessment, had to overcome their fears and worries in order to be able to share personal information with the pain psychologist as requested, and then finds that the assessment visit often ends without obtaining any real clarity from the psychologist in terms of what happens next, what the psychologist has concluded, or perhaps even what they will share with their doctor. This is a one-sided conclusion that generally will not motivate the patient to pursue further services, and the pain psychologist may feel trapped in this dynamic because they usually haven't had time at the end of their assessment visits to score questionnaires, complete chart reviews, or even organize their thoughts well enough to offer the patient with final recommendations. The solution to this dilemma is first, to make a point of providing the patient with what conclusions and recommendations you do have at the end of the assessment. And secondly, for those conclusions that require more time, routinely set up a follow-up by phone, in person, or even in writing as may be preferred in order to address these loose ends. The theme here is to make the pain psychology assessment as transparent a process as possible. The simplest examples consist of providing the patient with follow-up appointment times and referrals that you will be making, whereas more complex examples may be offering a general summary of what you will be reporting to the patient's physician regarding their implantable device candidacy, for example, or perhaps the diagnosis or diagnoses that you believe are appropriate and why, and what you will and perhaps won't be documenting in their medical record. Ending the assessment visit with a 5 to 10 minute component dedicated to providing the patient with feedback is a great way to ease their concerns and further involve them in their treatment planning. Even when the pain psychologist has recommendations that may be difficult for the patient to hear, it is much better to discuss these issues face-to-face during the visit, or at least as soon as possible with the patient, rather than having such recommendations come later from someone such as the referring doctor or pain clinic that was not involved in the pain psychology visit.